So I'm going to present another unusual case, which is submitral LV pseudoaneurysm, which is treated percutaneously. So as you would know that it's a very difficult situation to treat an LV pseudoaneurysm, especially in patient who has had multiple cardiac surgery. So our patient was 60 years old lady who had rheumatic heart disease and had mitral valve repair for severe mitral regurgitation at the age of 8 years, and then mitral valve replacement in 2009, and then she had again redo mitral valve replacement in a couple of years back in 2016, and was having paroxysmal atrial fibrillation. And she was normotensive, non-diabetic, hypothyroid, presented with complaints of weakness, fatigue, exertional breathlessness, giddiness, and uneasiness almost 3 to 4 months after being reasonably okay of the last mitral valve replacement surgery. And on examination, she had fairly stable hemodynamics, and chest X-ray and all was fine. And on cardiovascular examination, prosthetic clip was okay. And you can see that this is the chest X-ray, which looked like a post-cardiac surgery, which you could see that there is the prosthetic valve is there. So you can see that this is the prosthetic valve, and you can see multiple sutures of thoracotomy, which was evidence of 3 previous surgery. That there was this big pseudoaneurysm lying below the wall. So and this is again the echocardiographic picture, and if you look at the color Doppler, it was communicating with a narrow neck to the left ventricle. So this was the pseudoaneurysm, and this was connection, and we could find that this was directly communicating with the main LV. So obviously she was advised to have another cardiac surgery. So it has been seen that after repeated trauma to the myocardium, it could weaken, and then it may lead to pseudoaneurysm. It's like post-traumatic also it could happen, post-myocardial infarction also it has been seen. And there are case reports that in one of the patients, percutaneous left ventricular lead was being implanted, and after 3 weeks of that, the patient had pseudoaneurysm. So any kind of trauma on the myocardium of left ventricle, because left ventricle is a high pressure chamber, would lead to pseudoaneurysm. So for this patient, going for 4th surgery on the same ventricle, and that too, this one almost 6-7 months after the last surgery, was a problem, and patient was just not ready for any surgery. And then even the cardiac surgeons were giving high mortality figures, almost to the tune of 50%. So when we looked at this picture on echocardiography, we felt that the neck is narrow, and probably we will be in business, and probably things would be better. But we wanted a clear delineation, and before venturing into percutaneous closure of this pseudoaneurysm. So we wanted a CT picture. So this is how a CT picture looked like. You could see here also the small communication through the main ventricle. And then we did an MR of the LV aneurysm, and clear cut you could see that there is a communication here. Then we planned the things, and we felt that probably we would. So we had taken the both the Emplarger devices for ventricular septal defect and the duct occluder also, and then left ventricular angiogram in LAO projection, and you could clearly see that there is a large pseudoaneurysm like here in the inferior wall. And then this is the neck, and this was at a very angulated position. So we had difficulty. Initially we thought that probably we could cross this neck with the putting a wire into the pigtail that will guide probably through this, but we did not succeed. So after around 7-8 minutes, we took an Emplarger catheter, and it automatically flipped through the neck, and then over that we passed the wire. And this is the pseudoaneurysm angiogram, and you could see it's a really big one. But after this, the neck was pretty long, so we made a railroad over that, and the stiff wire Emplarger wire was used. And then through that we took a delivery sheath. So you could see that this is the delivery sheath, which has gone all the way from below the mitral valve, prosthetic mitral valve. You can see that the valve leaflets are moving nicely, and without hampering the valve leaflets, this delivery sheath went into the pseudoaneurysm segment through the LV, and then we removed the wire and loaded the device. So this is the place where initially we thought that device is nicely placed, but before that we took a shoot, and we saw that the device is still into the pseudoaneurysm itself, and so we had to recapture it and then redeployed it across. So this is the place where the neck was, and we need to come to that place. And to be more precise, we wanted to be under the transesophageal echo guidance, so that also gave us a confirmation that we are not at the right position. So we placed it again at the right position. So this is where we pulled it back, and this is the partial deployment of that, and under the transesophageal echocardiographic guidance we did that. So but this was just not seating properly, so we had to reposition and redeploy the device. So this umbrella, we pulled it back further, and under the tension we tried to put the spool of the device into the neck, and then the other side was delivered into the left ventricle, making sure that it's not abutting the prosthetic mitral valve leaflet movement. And once we are sure on a transesophageal echocardiography, we deployed it there, and this is the echocardiographic picture again showing that it's nicely sitting there, and it's almost 9 months of follow-up, and you can see the color echocardiographic color Doppler also that it is doing fine, and almost 9 months have gone. The patient's the episodes of atrial fibrillation has gone. It's become almost sinus, and the other thing is that the effort tolerance and everything has become better. This is again a still image of the same device which is delivered, and there is no, and the pseudoaneurysm segment is not expanding. In fact, the size has come down. So if you look at the discussion, the left ventricular pseudoaneurysm is a rare but potentially lethal complication of myocardial infarction. Previous cardiac surgeries, traumas, and infection could be there. Untreated pseudoaneurysm has a 30 to 45% risk of rupture within first year, so that's a very, very lethal combination. And surgical repair of the left ventricular pseudoaneurysm also carries a high risk of morbidity and mortality to the rate of almost 20% to 36%. And those who have got repeated cardiac surgery, it goes even higher, like in this patient. And surgery is better than medical treatment, which carries even a higher mortality of almost 48%. And although the emergent surgical repair is the preferred method of closing and pseudoaneurysm, but this method is percutaneous. If it is feasible, the mortality is very low, morbidity is very low. Patient could walk next day and can be discharged day after. Patients who have previously undergone cardiac surgery have a higher rate of morbidity and mortality after reoperations, obviously and understandably. An individualized approach should be used for every case because of the unique anatomical characteristic of the pseudoaneurysms, and size and location of pseudoaneurysm orifice, length of the neck, shape of the pseudoaneurysm cavity, and everything has to be studied. And if we do it in the CT and MR guided and imaging, then we had an hybrid lab where we can overlap the whole pictures, and that makes job easy. And for pseudoaneurysm with very long neck devices that have got a lengthiest waist, like implanted duct occluder or muscular VSD occluder, are warranted. So to conclude, chairpersons, I would say that the percutaneous closure is an effective way of treating the LV pseudoaneurysm, and particularly in post-op redo where surgery is technically very challenging. Appropriate patient selection is important to decide among the treating modalities like device versus surgery. And in the era of variety of devices and different dimensions, we should always consider percutaneous device closure as a first priority to decrease the mortality in these group of patients. Thank you very much for your kind attention.